Okay, welcome to our last TBL day for Bio 140. This will be covering the last section that's going to be on Exam 5, which is the fluid balance, urine clearance, and pH balance. Okay, so this figure is directly from your book, figure 25.1, and I'm not going to uncover these. I want you to go to figure 25.1, fill these in. Really what this is looking at is here total volume of body water. And then of that total volume of water, how much of that is found inside of cells, how much of it's found in the interstitial space, how much of it's found in the blood, the plasma volume. And you'll see that extracellular fluid includes plasma volume and interstitial fluid. And so just in general, you're going to need to know what percentages of the fluid is found inside the cells or outside the cells or in the blood. Okay, so of that, all that water we have in our body, we're going to talk real briefly about how we regulate how much of that fluid leaves the body here on regulation of fluid output. And then the next slide will be how much of that fluid comes in, so regulation of fluid intake. So on the output side, most of our water loss is what's called obligatory. We can't really control it. It just happens. We have to use fluid to get rid of urea in our urine. That's the nitrogenous waste by breaking down proteins and nucleic acids. We have to have water to get rid of feces, to regulate temperature, and to breathe because the air needs to be moistened. So those are things we have to have that water loss. But we can regulate the amount of urine that we have. And so these are done mainly by the hormones ADH and then the renin, angiotensin, aldosterone system, which we discussed last time. So the fluid intake regulation is a little bit different, and this is new to this section. So one is by thirst, obviously. How much we take in is how thirsty we are. And so the thirst control center is found in the hypothalamus in the brain. And so if we have an increase in ADH release, then we get thirsty. That's one of the effects of ADH is thirst. This becomes less sensitive as we age. Another interesting thing is if our mouth is dry, that also stimulates thirst. And so we actually get some quenching of thirst just when water is in our mouth. And before it even actually goes into our stomach where we can absorb it, we get some quenching when it's actually in our mouth. And so the reason for this is that this kind of helps. This is down here. This kind of helps us to not take in too much water and prevent dilution of our body fluids. And so another mechanism here is that the inhibition of thirst follows drinking, obviously. So when that water actually gets down into our stomach, we get some stretching of our intestinal walls, and we have stretch receptors found in the intestinal walls, and this is going to quench our thirst as well. Okay, so as far as ion balance goes, is a very important part of fluid balance is also ion balance. And so it's very key to know that sodium is the primary determinant of tonicity in the body. Okay, whether your body fluid is hypertonic or hypotonic is primarily determined by the level of sodium you have in your body. Okay, and this is going to be primarily regulated by the proximal tubule in the kidneys. And so most of the sodium that gets filtered out of the blood in the filtrate and the glomerulus is going to be reabsorbed immediately right there by the proximal tubule. The distal tubule can reabsorb some too, especially in the presence of lots of aldosterone. And so we'll talk some about that here in a sec. And so another key thing to note is that the potassium is the major cation of the intracellular space, where sodium is the major ion of the extracellular. Potassium is a major ion of intracellular space. And so the proximal tubule, both sodium and potassium move together with water. So we don't really have any regulation of potassium here. At the distal tubule, it's different. Sodium and potassium are exchanged for each other. So if sodium's coming back into the body, potassium is going out. Okay, so when we have aldosterone release, the more aldosterone we have being released, then the more potassium we excrete and the more sodium we reabsorb, meaning bringing back into the body. So this is just a summary for you. I would highly recommend you filling all of this in. This will definitely help you with the TBL quizzes on Monday. Okay, so now this next few slides here is just how you're going to calculate a stat called renal clearance, and you're going to need to know how to do these calculations for the IRAT and the TRAT. And so the definition of renal clearance is the volume of plasma from which a substance is completely cleared by the kidneys per unit of time. Okay, so in order to calculate this, we need to know a couple things. We need to know the amount of a substance in the plasma, as well as the amount of substance in the urine, and then how much urine is being formed. Okay, so the reason we care about this is one example would be for pharmacists, as is shown down here. Pharmacists must know the renal clearance for drugs in order to determine the correct dosage. If we know that a drug is cleared very, very rapidly by the kidneys, then what that means is that dose is going to have to be higher to keep the level of that blood, the level of that drug up in the blood at a certain rate. If the drug is cleared very slowly, then we're going to use a low dose because we don't want to have too high of a level in the blood. So 3 different possibilities here. So first of all, the equation. This equation, you'll need to use this in the next few slides. Renal clearance equals the amount of the substance in the urine, which is the U. V is the flow rate of urine formation, so volume of urine. And then P is the concentration of the substance in the plasma. Okay, so it's how much did you start with in the blood, how much came out in the urine, and then how much total urine came out. Okay, so now GFRs are glomerular filtration rate. So this is just how much filtrate is being created in the kidneys. Okay, and so we need to know that for all of these. So if renal clearance is exactly equal to GFR, what that means is that this whatever substance it is that we're talking about was freely filtered, meaning that all of it got pulled out of the blood in the kidneys. That's why it equals GFR. It's not secreted, meaning that we don't add any more of that substance to the filtrate as the filtrate goes through the kidneys, but we also don't bring any of it back. That's what not reabsorbed means. Okay, so if RC equals GFR, this is what you get. And so there's a few things that are like that: inulin, creatinine, and we use both of these for calculating kidney function, because if we know the renal clearance of one of these, then we know what GFR is, and that's a good measure of how well our kidneys are functioning. Now, the other example is if renal clearance is lower than GFR. If renal clearance is lower than GFR, then we know that the substance is filtered and reabsorbed. So, meaning that we put it into the filtrate when it went through the kidneys, but we brought some of it back. That's what the reabsorb means. Okay, so sodium happens this way, glucose, amino acids, things we want to bring back because the body still wants to use them. And the last example is with renal clearance being greater than GFR is it's filtered into the urine, and then it's secreted, meaning that as the urine goes through the kidneys, we add more of that substance in. Okay, so potassium can be that way, and then mostly all drugs. With all drugs, the kidneys have to work hard to get those out of the blood and into the urine. So that's why we see this. We're adding more as it goes through. Okay, so the next 3 slides have examples of 3 calculations, and so I'm not going to do these for you here. You need to use. I give you the 3 variables that you need. You need to use that equation, calculate renal clearance, compare it to GFR right here, and then figure out which one of these is the case. And then it would be a good idea to know the examples of substances in each of those 3 categories from the previous slide. Just skipping over these slides here. Okay, so another very important part of the urinary system is acid-base balance. We've talked about how the lungs are involved, but we're going to talk about how the urinary system is involved. So obviously we've mentioned this a lot throughout the year. The enzyme function is very sensitive to pH, and that's why we care about acid-base balance. If we get too far away from normal, proteins denature. Ion solubility changes, meaning that bones can start breaking down because bones are made up of ions. And if the solubility changes, those bones can start dissolving. And so that's why we care. And then we know that buffer systems are very important to maintain pH. And so the purpose of the buffer system is really to prevent major changes in fluid pH. And so the components, as we already know from before, we need to have a weak acid and a weak base. And this figure very nicely shows the difference between a weak acid and a weak base. So I'll let you go ahead and read that and refresh your memory on that. So again, we're going back to our major buffering system in the body. And as you guys know, that's the bicarbonate buffering system. Okay, and the bicarbonate buffering system equation is shown right here. Okay, and so you can just take a second to refresh your memory on which one is the acid and which one's the base, because we know we have an acid and a base in each one. And so obviously we got carbonic acid here and bicarbonate. This is the acid, this is the base. Okay, so the two examples now, if we, this is just to refresh your memory on acid-base balance. So in the situation where we have this buffering system, if we add bases to that solution, the response by the buffering system is, going to add protons, right? It's going to add protons, okay? So adding hydrogen ions to get that pH back to normal. And so that's going to move the equation to the right. We need to dissociate carbonic acid into hydrogen and bicarbonate so we can add these protons to the solution. And that's going to move pH back down. Okay, if we have the other situation with an addition of acids, meaning we're adding hydrogen ions to the solution, those hydrogen ions, those protons, are going to bind to bicarbonate that's already there, and that's going to push the equation to the left, right? So the pH is going to go back up. So definitely need to know that and understand that. Okay, so a little bit about the kidneys' role in pH balance, okay? So the kidneys can get rid of hydrogen ions or bicarbonate, or they can conserve either one of those. And so there's two main types of cells that we'll talk about that do this. And so we have the enzyme carbonic anhydrase, which we've already talked about, inside the tubule cells that line the kidneys. Okay, and so there's type A cells, which their job is to secrete hydrogen and reabsorb bicarbonate, meaning that they get rid of hydrogen, put it into the urine, and pull bicarbonate out of the urine and bring it back into the body. Type B cells do the opposite. They reabsorb hydrogen and secrete bicarbonate. So type A cells are much more active because the body is typically going to be making acids from metabolism, okay? And so we're usually trying to increase the pH in the body and fight against the shift of moving it to be more acidic. Okay, so what I want you to do in this slide here is I want you to take a look at the steps involved with the way that the type A cells in the kidney tubules deal with too many hydrogen ions and how they help us with acid-base balance, okay? And so the steps are shown right here, okay? And these steps will coincide with the figure on the next page. Okay, so this slide here shows in a picture format the steps that were shown on the last slide. So you can kind of use your textbook here. This is right from figure 2511 in the textbook. I want you to fill in the steps, what's going on here. I've added a little bit more detail that the textbook didn't have by the exchange with chloride there, or by co-transport with sodium, or primary active transport using ATP. And this is really how our body is helping us, our kidneys are helping us deal with pH. You can see that the kidney cells are pumping hydrogen ions out into the urine and putting bicarbonate into the blood, but also pulling CO2 out of the blood and into the urine is an important part, one, to be able to make hydrogen, and two, to be able to make bicarbonate. And the bicarbonate is obviously a buffer, so if that goes into the blood, that helps us, and if the hydrogen ion is the thing that's dictating our pH that goes out of the body, that's obviously helping us too. You just want to think about, by using the previous couple slides, which type of cell this would be, type A or type B. Okay, so we've already talked a lot about the respiratory system and how it deals with pH, and so I'm not going to go over this again, but you can read over this just to refresh your memory. Okay, so we're going to end this with just talking about respiratory and metabolic acidosis, as well as respiratory and metabolic alkalosis. Okay, so respiratory acidosis, the definition is a pH of 7.35 or lower that happens because of not breathing enough, hypoventilation. Okay, the two main causes of that are emphysema and taking too many narcotics. Narcotics like morphine affect the medulla and slow down its function and cause you to not breathe. That's how you can overdose on narcotics, is you just stop breathing. And so emphysema is actually obviously hard to breathe and hard to push air out of the body, and so you can get a buildup of CO2 because of that. And that's the whole deal with respiratory acidosis, is you don't blow off CO2 fast enough, and so you build up hydrogen ions in the blood. And so the way that the kidneys help compensate with this is to shed more hydrogen by excreting more hydrogen in the urine. Okay, so then metabolic acidosis is that we're making extra hydrogen ions. Respiratory acidosis is we didn't get rid of the CO2 and then didn't get rid of hydrogen ions, but here we're making too much. Okay, so the causes can be ketone bodies in diabetes mellitus, which we'll talk more about later. Starvation can also do this, both due to liver forming ketone bodies or because of severe diarrhea. So if we have severe diarrhea, what happens is we lose all of the bicarb-rich juices that come from the pancreas, and so we're getting rid of too much bicarbonate, and that leads to acidosis. So the way the body deals with this is, one, by increasing ventilation. This would blow off CO2 and increase our pH, and the kidneys also fight to excrete or secrete more hydrogen. Okay, then on the alkalosis side, alkalosis, the definition is a pH of 7.45 or higher, so again, a very tight range of pH that's acceptable. And this can be caused by hyperventilation, breathing too much. Okay, and so we talked about this already. We breathe too much because we're anxious or because we're at a high altitude, and we blow off our CO2, and then we decrease hydrogen ion levels. And so the way that we compensate for this is by decreasing the amount of hydrogen we excrete in the urine and increase the amount of hydrogen we bring back in the urine. And lastly, metabolic acidosis, metabolic alkalosis, is from losing too many hydrogen ions. Okay, so some diuretics can do this by making us urinate out too much hydrogen. And the other real common cause is by vomiting, since our stomach is very acidic. So if we have the flu, or we're self-induced vomiting, or any kind of too much vomiting, we lose stomach acids, which can lead to a drop in hydrogen ion concentration in the body, and this can decrease urine output of hydrogen ions. Or the way that we deal with this, is by decreasing urine output of hydrogen ions or increasing reabsorption of hydrogen ions. And then on the lung side, we just slow down our breathing rate a little bit, which holds on to more CO2 and can offset this. So make sure you can understand the details of these different types of alkalosis and acidosis, the causes, and the way the body compensates. That should do it.